with both speakers, but there may be an opportunity where one of the speakers may present additional information towards the end. We'll see how that flows. With that, I'd like to begin the introduction with a dear friend of mine. Back in the mid-1990s, we were both lifelong educators and served on, I think it was myself who asked Frank to join the editorial board of the Journal of Extracorporeal Technology, and Frank served for many, many years on that. But to begin, Frank has a nursing background. He's a registered nurse in addition to a European board certified perfusionist. He graduated from the Academy of Perfusion from Herzontrum in Berlin in the mid-1990s, and then received his doctorate degree in theoretical medicine from the Humboldt University in Berlin. He serves on multiple boards and directors. He's been the director and lecturer at the Deutsche Herzontrum Berlin. This is where I know my personal experience has been with Frank for many, many years now, over 20 years. He's both the director of the Steinbeiß Transfer Institute on Cardiotechnique and is the academic director for the DHZB Academy of Science. He has multiple memberships on numerous organizations, including the European Board of Cardiovascular Perfusion. He served on multiple editorial boards, both Perfusion Inject, as well as the Interactive Journal of Cardiothoracic Surgery. He is well published, and some of his more recent publications are focused on education, the content that we're going to be talking about tonight. And this is where he's published on simulation extensively, stress levels in cardiovascular perfusionists, and of course was a co-author on the 2019 ECCP guidelines on cardiopulmonary bypass for adult cardiac surgery. And in tonight's presentation, I apologize, although it was up on the slide, I will state it before I defer to Jeff to introduce Ben. But the title of our presentation tonight by Ben and Dr. Merkle would be Rethinking Perfusion Education, Expanding Clinical Roles and Application. And with that, I'll turn it over to Jeff to introduce Ben.
Thanks, Al. Benjamin Haupt has been a perfusionist for 10 years at Charité and currently maintains clinical duties there for 1 day a week, just to remain in practical touch within the field. He attained his master's degree in medical education at Charité University and currently holds the position of deputy director within the Academy of Perfusion. He teaches classes with Dr. Merkle and other fellow colleagues. Ben, Dr. Merkle, welcome. Ben, take it away.
All right. So my screen should be visible right now. Dear Al, dear Jeff, thank you so much for having us today. Here in Berlin, it's 11 o'clock p.m. And thank you so much for the kind introduction. Ladies and gentlemen, I'm so pleased to speak about the current changes in the roles of clinical perfusionists and the changes and the teaching accordingly. Wait a second. I have created 3 parts for this presentation. Part 1 is the ongoing changes in cardiovascular perfusion. In part 2, I'm going to speak about the changing work fields and advanced perfusion techniques. And part 3 is the part that I speak about contemporary methods in teaching and training future expert personnel. It was back in the year 2012 when we published an article. It was called State of the Art in Cardiovascular Perfusion Now and in the Next Decade. And when we read it today, we focused mainly on the heart-lung machine in general, the cardiopulmonary bypass, like biocompatibility, monitoring of parameters, knowledge-based and evidence-based medicine, but also on the team approach and best practice on perfusion. But it was still focused mainly on the cardiopulmonary bypass itself. The factors that indicate the changes in cardiac surgery are mostly, first of all, the growing population, especially in the metropolitan areas like Berlin, with almost 4 million people right now. Secondly, the demographic changes. The classic middle part is moving upwards. So the population is getting older, as we all know. And third, the development of diagnostics. We can diagnose more and better today than in the past years. And when we look at the numbers in Germany, we see that over the years, the classic age group in cardiac surgery is slowly shrinking, while the younger patients and the older patients, like octogenarians, are getting bigger. These groups are getting bigger. And I believe that these changes can also be seen in the United States. I would be very happy to discuss this later on the Q&A section. If we look at the cases, we see that, for example, the bypass surgery, CABGs, are decreasing year by year, like 5% in 2 years, while aortic surgery is increasing, and also the assist device procedures. And if we take a look at the development at the German Heart Center, we see that from the beginning of the program in the year 87, it was a constant rise. And now by January 23, we have reached the number of 400 patients being treated actively within LVAD. If we look at the cases in the German Heart Center using cardiopulmonary bypass, we see a constant decrease, like this line downwards. And even if we estimate the year 2023 numbers, this is estimated because we merged together with the Charité, German Heart Center, and Charité took a fusion, and we still will not reach numbers like over 3,000 cases per year. Last year, we didn't even have 2,000 cases on cardiopulmonary bypass. And these numbers reflect also, again, the developments in Germany. Like we have constant numbers of 78 cardiac centers, but the operations are decreasing year by year. Taking a closer look on CABG surgery, over the last years, we saw at the German Heart Center a straight development towards the off-pump surgery. So the numbers done off-pump are increasing. And now it's almost a rare kind of thing using the heart-lung machine on the CABG. Looking at the numbers, again, at the Heart Center development of the catheter-based valve interventions like TAVIs or MitraClip, since the beginning of the program in 2008, there was a constant rise. And this specifies the numbers in aortic transcatheter procedures. Also, again, the numbers in Germany, I guess the graphic speaks for itself. The cases done conventional, they are slowly decreasing, and the transcatheter procedures increasing year by year. So allow me a little outlook. When it was state-of-the-art in cardiovascular perfusion, now and in the next decade, in the year 2012, we jump forward to today. We should maybe rename it like state-of-the-art in cardiovascular perfusion. Where do we go from here? And I proceed with my second part, and please allow me to speak a bit about advanced perfusion technologies. I can only focus on some of them due to limited time today. I start with the minimal invasive extracorporeal circulation. Since the beginning, the change of the millennium, like in the year 2004, the first publication was published. And in 2014, the society, the MIECTIS Society, was founded. And slowly after, the first position paper came out defining the types of MIEC systems 1 to 4. We still have this COMIX trial, a multi-center randomized controlled trial with many cases combined. And in the year 2021, there was a focused update position paper on MIEC. This is our system in Berlin, MIEC type 4, sorry. And we use it basically for LVAD implantations and CABG surgery. The increased use of MIEC systems also demands new methods of teaching. So in the Academy of Perfusion, we developed specialized multi-professional MIEC workshops. Like here you see Frank and Adrian Bauer teaching a group of perfusionists on a MIEC system in our simulation room. And this is a repeated workshop that we will continue. Further is the continuum of the comics trial, and the MIEC technique itself was the inspiration in some ways for minimal invasive perfusion techniques, such as the percutaneous thrombus aspiration. In Berlin, we use the AngioVac system, and we have done in numerous cases in the meantime. This picture, you see some lead vegetations being taken out in open heart surgery on pump using the heart-lung machine. This is the later result that you see. But this always involves sternotomy, cardiotomy, cardiopulmonary bypass, hypothermia, complete anticoagulation, while the percutaneous aspiration with this suction cannula is a minimal invasive procedure, like a venous circuit in normothermia with mild anticoagulation. A schematic setup of our system at the German Heart Center, and a close look on that. And you see features of MIEC here, the bubble detector, an occluder, so to make it very safe. Here's some of our captured material. You see that the thrombi can appear in numerous ways, like in small fragments or as a whole. But we had very good numbers and successful procedures in the past years. Another field of future perfusionists or ongoing perfusionists duties is the pulmonary endarterectomy. Here are some pictures. I guess you see it speaks for itself. The pulmonary artery pressure is almost systemic here. And for these people suffering from the chronic thromboembolic pulmonary hypertension, the operation is the only way how to be treated. And this involves mostly cardiopulmonary bypass and profound hypothermia and circulatory arrests for about 4 times 20 minutes. So this will be a field in the future time where perfusionists will be demanded. This is a picture of the lung being malperfused in many ways, and this is the later result of the extracted material. Another field is the protective transport of donor organs. We moved on from cold static storage to ex vivo perfusion systems. And the development was described in this publication, from cold perfusion to beating heart transport, and now to non-ischemic preservation systems. For example, we used the ex vivo life box in cardiac transplantations. Here are 2 pictures from our operation room. And this system itself, it's a system with continuous perfusion with a specialized solution in hypothermia. It has to be maintained a certain perfusion pressure constantly at 20 millimeters Hg and a balanced pH. And this, as you see, it almost calls for a perfusionist. And also, if we look at the parts of the system, there's an arterial filter, an oxygenator, tubing segments, priming line pressure, and temperature sensors. This also calls for a perfusionist. And there's a lot of research ongoing as well in Europe as in the States. You see here, for example, Hanover, Germany, Sweden, and 2 hospitals from the United States. A vast field, and this was also mentioned in the introduction, is the mechanical circulatory support, like L or R VADs, impeller, ECMO, ECLS, and more. And I will describe you what I mean with the way to the ICU perfusionists. The ELSO reports show increasing numbers in the use of ECLS, for example. And here again, some numbers of our center. You see the increase until the year 2016, and there was a drop that could be partially explained with the renaissance of the impeller that took many of these patients from this group away, but we still have a lot of cases, like almost 200 per year. And here's an excerpt from the current guidelines in Germany that focus on the implantation of ECMO and ECLS. And it clearly states that ideally the multi-professional implantation team should not only include specialized physicians, but also clinical perfusionists. So this is the hard facts about the implantations. And as you all know, we as perfusionists take many tasks in the ECMO and ECLS treating, like transportation of patients. My colleague Stefan was so kind to give me some of his transport pictures. For example, here one is in the ground transport, the other in the helicopter. So there's always a perfusionist involved. Also maintaining the ECMO and ECLS on ICU. Here, for example, you see a double oxygenator for increased oxygenation. Or here on the right side, you see a system combined with a dialysis machine. And we have experts in Charité that don't work in the OR anymore. They exclusively conduct these systems on the ICU. That specifies the demand that it takes. And up in the year 2023, right now, we have 7 persons, like fully qualified perfusionists with a valid European board that work exclusively on ICUs in Berlin. So no more OR for these people. We offer in the academy certified courses. This is what Frank will maybe speak about later on. And the next one is starting tomorrow. And these courses are highly demanded. They are sold out in minutes. And tomorrow we're looking forward to see many multi-professional teams from different hospitals here in our institution to teach and discuss again the use of extracorporeal life support. Also in pediatric perfusion, there's a huge demand in development. For example, I have only taken out one picture. That is our colleague Wolfgang with our chief surgeon in pediatric surgery. And he's showing our machines for the smallest patients. It has a priming volume of 72 milliliters. This is actually the smallest heart-lung machine so far on the planet. And it allows an sound use priming even for neonates. And this development took about 10 years and is now clinical practice in our center. I'm leaving the field of the medical procedures, and I want to speak briefly about mental and cognitive stress research, because this was a main focus that we did in the past years. For example, acute complications, the oxygenator failure that we use. We developed a system that allows the old oxygenator, when it has a loss in gas transfer, to be still in the circuit without an oxygenator changeout. with an additional one in the venous line. And this was used in pediatrics very successfully a couple of times, and also in adult perfusion. Another complication, severe bleeding on ICU. In this case, the patient would not be transported down to the OR. The whole team had to come up to the ICU, including the heart-lung machine that you see here on the right side with my colleague Stefan right behind it. Luckily, the patient survived, but it also indicates what kind of stress levels occur. And that makes perfusionists like an ideal research target group for stress research, complex tasks, behavior in the event of complications and incidents, and also specialized communications. And from our program, we had, for example, created a critical events checklist on oxygenator failure that Frank successfully published as well. And we will, I guess, publish more of these little helpful tools for the field in the future time. We evaluated these, and the results were like many people, especially the newcomers on the job, were really appreciating to having small helpful checklists for emergencies like this. Another interesting figure from a publication of Diaz et al. Shows different stress levels in different groups, like the anesthesiologists, the perfusionists, and the surgeons. And it's interesting that perfusionists maintain cool all the time until the initiation of CPB. But then you see clearly an increased stress level here. And this was similar to what we found in our perfusion simulation project that we did. Here are some current pictures, but this is still the how the simulation operation room is it's done. You see the upper left picture shows the anesthesia workplace, and on the bottom you see room cameras showing the perfusionists. And here is a group being trained by Frank. I jump a bit. We found that through the review of literature that the evaluation of perfusion simulation is rare. And we found like 5 or 6 publications that focus on the evaluation of perfusion simulation. And that led us to the simulation project. This combined different fields of research. For example, an eye tracking project where colleagues, newcomers and experts were wearing these eye tracking glasses and also biometrical sensors. And here's, for example, a comparison between the real operation room on the left side of the picture and the simulation room on the right side of the picture. So we looked not only the different rooms, but also the, I call them rookies versus experts. And you could clearly see there's a difference between beginners on the job, that the areas of interest go all over the place of the machine, while the experts had very certain points that they were looking on, especially in the initiation of cardiopulmonary bypass. We added also to the quantitative research a qualitative part where we did semi-structured interviews, and we found that the simulation was really appreciated by the colleagues, and they saw it as a very good additional tool for their, even for the experts, for their development on the job. So there were numerous papers published, all of them with different focus, but all about the simulation project. And I'm coming to the third and the last part of the presentation, the contemporary methods in teaching and training future personnel. Here's tasks of the nowadays perfusionists. While in the past times it was mostly heart-lung machine, then came ECMO, ECLS, a bit of rhythm therapy. But now we see that there's MIEC, there's specialized CPB, there's in and out of hospital ECMO ECPR, there's in the centers that transplant organs, the transport of the donor organs, the whole part of the ventricular assist devices, also in research and development, the coordination, the preparation in the OR. Many colleagues now take certifications in rhythm therapy, like they become experts in ICD or cardiac synchronization therapy. So this gives an overview of how many tasks nowadays perfusionists must fulfill or can fulfill. And our dear colleague Adrian has published a paper, and it's like a position paper on how what qualifications, tasks, and knowledge should the clinical perfusionist have. This brings me to the point of our institution. How do we offer all these different things in our curriculum? This is just an excerpt of what we teach, and here you see this is in German. I apologize for not having translated this, but it focused, for example, on mechanical circulatory support, and this is lessons like in the mid of the education. Then there's parts about ECMO, ECLS, and then there's practical tasks as well, like here an oxygenator change out in the middle. The classics like intra-aortic balloon pulsation, also pediatric perfusion. And we also mixed the ways of teaching. This was due to the pandemic that we had to switch from one day to the other to online teaching. And thanks to Frank, we didn't lose a single lesson because he was the one who set up an emergency Corona studio so that we could do online lessons right away. But we kept some of these techniques because, for example, when we have an expert speaking on a certain subject and he cannot, or he or she cannot come to Berlin, we have them online as an online seminar, just like we do this today. Here's some pictures of last year's, for example, Frank here on the upper right picture giving an online lesson from his desk on, while I'm doing a hybrid seminar with half of the group being in the classroom and half of the group is at home and taking the lesson, looking at the lessons from home. This was due to the Corona restrictions that we had. We could only allow a certain number of persons in one room at one point. And we went on. We developed, like here you see in the lower picture, methods. We had live transmission from the simulation room because we couldn't offer the students the practical training that we usually give them. And let me close now slowly with some numbers and some pictures from the Academy of Perfusion. Here you see from the beginning on the development in numbers, that the numbers of students that we have at the Academy. And we had a peak in 2021 with students, and they are all highly search for persons. The person, they are hired right away and they are needed all over places. Here's our graduation class, brand new from this year, and 4 of these persons luckily help us now in the OR at Charité. And 2 last slides from our vision of 2024. We definitely want to increase the simulation room. We are working right now on not only having a simulation OR, we also work on having a simulation ICU room, and our dream is to have an interventional OR with all the equipment for X-ray and picturing. And we will, in the future time, move on to another building as well. We dream about a nice new location very close to the Charité campus and as a part of a biomedical technological campus here in Berlin-Wedding. And with this future plans, I come to my conclusion. So the field of work in cardiovascular perfusion is changing. We have less routine cases and routine perfusion, more requirements in specialized and complex perfusion techniques. And also an increase in tasks outside the OR and up to the point where perfusionists work on ICU exclusively. Perfusionists is still becoming an interesting group in research on mental cognitive stress and human factors. And the CPB as a primary tool is supplemented and replaced even by an expanded spectrum, but still perfusion technologies have a future as part of a multi-central, multi-professional team and modern medicine approach. And ladies and gentlemen, thank you so much for your attention. And I leave you with one picture of the night in Berlin because we're approaching midnight here. And thank you very much for your attention.
Thank you very much, Ben. That's a fabulous presentation. I really appreciate the time and effort you put into that. A lot of great things to chew on. Before we get to the discussion and the question and answer, I just wanted to open it up to Frank. Is there anything you would like to add or anything that you can that you'd like to comment on at this point?
Yeah, first of all, I'd like to thank Ben as well for this excellent overview. As you have seen, of course, not every single team member is performing all the tasks. You have a very large group of perfusionists, about 25 perfusionists in the hospital environment, and some of them are specialized. But the problem is, like, as we have talked about this, Jeff, before this webinar, also when I started perfusion equaled perfusionist was running a heart lung machine. That was the end of it. And now we have very dispersed jobs to do. And what Ben was showing at the end, a little bit how we teach, we didn't very detailed that. But one thing that we are going to change and that we have to change is we have to bring in more science, like biomedical science as well, because we have been very traditional with like application of medical technology, but we didn't focus so much on the ground of the foundation of all that knowledge. So, and one thing that we are also seeing is that imaging is becoming more and more important, like hybrid operating rooms. Perfusionists are running imaging machinery. So we will have many more roles to fulfill in the future. And I think this is one very exciting part of being a perfusionist, is that it's ever changing and has a lot of increased demand. And last word is simulation is a very good tool, but it's limited to the hardware that you have. And so in the very near future, we will switch over to virtual reality. I'm quite sure of that, because then you'd have the opportunity to a lot of more and newer technology and maybe also combine this with the latest developments. Yes, thank you.
Oh, thank you, Frank. I did, since you mentioned simulation, I had a question kind of concerning simulation. I know you introduced it here. I know in the States we're also introducing simulation in perfusion education. A couple questions regarding it. Is there an average number of simulations that your students perform before they go out on their clinical duties? And then the part two to that would be, and I think you kind of pseudo answered it, is, are you developing other areas of simulation like ECMO? And I know you had said it depends on the equipment available, but currently we're trying to also parallel an ECMO simulation so that students, as they go out, they're well versed in that.
Yeah, first answer is that we don't train the students like completely, and then they go out to the practice because they're actually employed by their own hospital. So they are working. Sometimes they are already working in a perfusion department, and they've been sent to the school, to the academy to get the formal training. So what this means is we have no way of giving them all the simulation before they ever go to the operating room. So we do it on the fly. And this means that we will have typically 3 to 4 different times in their training. Like the picture you just saw of those students, these were in the academy the second day of their perfusionist career, and they were already put in front of a heart-lung machine and tried to come off bypass and so on. So we have 4 different stages from the very first days until to a more comprehensive training, more techniques to complication management. So that's over the course of 2 years. But the second answer, of course, heart-lung machine or CPB is only one part, and then ECLS, and also obviously ventricular assist devices and these things. Some of these you can easily simulate, others are a bit more difficult to simulate, and that's why simulation is a very good tool, but it is fairly limited to the techniques you can offer in that setup, in this setting. So I think this part will develop very quickly now, and maybe in 5 or maybe 10 years from now, we will have many more techniques available to suit the needs that we have.
Great. Frank and Ben, thank you so much. I'd like to shift to some of the questions, excuse me, that are coming off of the internet. Friend and colleague Maureen Gray asked a good one. The American Society of Extracorporeal Technology just published their updated standards and guidelines for perfusion. And as a guideline, meaning that it's not highly recommended, but it's suggested, they're shifting to an N+1 model, which actually was also in place before then. The N+1 model just means that there's another person available to assist the perfusionist during the operation, more so than, a nurse or somebody else, somebody who's dedicated to perfusion. Either Ben or Frank, can you comment on what it's like in Europe? There's such a similar model that the European board recommends, or a professional society recommends, that basically 2 individuals are available for each cardiac case requiring a heart-lung machine.
Yes, I just answer this quickly. It's the same situation. It is a little bit different doing on-call because usually you would not have a second perfusionist on the same case. So this is usually during the day. But there's actually a paper, a consensus paper, another one about the structure of cardiac department in Germany. This is issued by the German surgeons, cardiac surgeons. And they state that there must be an extra perfusionist be around for emergency regions. But this is usually only adhered to during the daytime, not so much during night shifts.
Thank you. And Ben, if I could follow up real quick, Jeff, if you don't mind, with a question from Julie Fensky. During your presentation, there wasn't much that I saw in regards to intraoperative blood management, auto transfusion. Yet this is a huge practice area for perfusionists in America, usually double the caseload that we have for open heart. And it's growing. That's something that we see taking off, especially for spine surgery, general surgery, and other areas. Can you talk about how the European or the German Heart Center or European perfusionist addressed auto transfusion in your practice?
Yeah, thank you for this question. We are all taking part in transfusion therapies, not only on cardiopulmonary bypass, but also creating autologous blood products, like this autologous glue. We are also trying to lose very little blood on the process. So we operate cell savers as well. Many perfusionists operate cell savers in the hospital. So we're very close in this field. Is it the answer to the question?
Yeah, and recently in America, well, I guess 10 years ago, we started the International Board of Blood Management by AMSEC, dedicated specifically to not only perfusionists conducting autotransfusion, but also other practitioners who are not regulated. So here in the States, we've had a huge push on basically standardizing autotransfusion, including simulation laboratories. UPMC has a wonderful autotransfusion sim lab that they train many individuals that go through. And we're seeing more and more of that in the United States. We're just interested, and especially Julie, I'm glad she brought that up, to see how you address that, or if it's something that you would add to a future growth and development in Europe.
Yeah, in this case, you are one step ahead. That you have this board and even the simulations about this. There in Europe, there is an ongoing discussion about this, but we don't have this. How did you call it? This project?
The International Board of Blood Management.
Yeah, exactly.
Well, I'm glad you said that we're ahead of you once. I think most of the time, we look at what the future has. We look to our European colleagues and Australasian colleagues as well. So thank you for that kind comment.
Yeah, I wanted to ask a question for Julie Fenske's got a question concerning perfusionists that are dedicated to the ICU. Do they have to pump any cases to maintain their certification? Because in the US, we have to pump 40 cases minimum to remain certified. So for those dedicated to your ICU, is there a clinical requirement for them to maintain?
This is exactly the same thing here. They have to perform 40 cases annually to maintain their board certification. So these persons that they're working on ICU exclusively, they have to go to the OR to perform cases, which is possible, to maintain their license, like their board license.
Jeff, if I can ask I have a comment for both Ben and Frank, and then a question. Ben, in your slide on the German Heart Center cases, it looked like OPCABs are greater than 50% of at least the coronary procedures, and led to a big decline to on-pump. Correct me if I'm wrong. In America, the opposite has occurred. In fact, it's rare that you see OPCABs anymore. I believe the last STS data, it's under 13%, maybe even 11%, but it looks like it's on the rise in Europe, especially at the German Heart Center, despite overwhelming evidence that really has not shown it to be beneficial out of a very few cases. Can you describe why that's occurring? And is that specific to the German Heart Center, or do you think that's something that's true across Europe?
Frank, do you want to answer?
Yeah, I can. Actually, I think it's both surgeons' preference or institutions' preference as well. I'm not so much based on real evidence. I mean, there has been the same has been going on in Belgium and Netherlands years ago, and then they reversed it, and so we see this sometimes. It's like a fashion. It happens. So in our hospital, we have a few surgeons that are convinced OPCAB is much better for patients than on-pump, but only for isolated CABG patients, and it's hard to discuss with them. But of course, well, we do whatever is needed, but I think it's not universal. It's not the same for every hospital. It's not the same for every European country. This is quite diverse.
Yeah, it's interesting that the difference that we see in America, and at least the German Heart Center. Your numbers are going up, and we're all going down with OPCAB. So it seems that a lot of people are only using it for very specific cases, and I think most of the research that's presented recently has promoted the use of on-pump as a superior technique for revascularization. But let me shift for a second, because both of you are leaders in the field of simulation. And a question that I always had is piggyback to what you said in regards to stress. And thanks so much, Frank and Ben, for addressing this. It's definitely on the forefront of all of our minds. Every perfusionist can agree with you. But is there any research that, let's say, shows individuals, especially those who have trained in the last decade when high fidelity simulation has seemed to taken off, those individuals who've trained under high fidelity simulators and have gone through courses such as the German Heart Center and also in America, that they actually respond to stress in a different manner than individuals like myself and perhaps Jeff and Frank and maybe even Ben, who perhaps didn't grow up with simulators and use real life experiences to mitigate stress. Is there any research that shows that
I'm not aware of this in the world of perfusion, actually, because I think the perfusion society is just too small. But this is a very, very interesting point. I mean, what you can train in the simulation setting is the specific reactions to certain conditions that you can train, and then you obviously, if you repeat it and you train on something, your stress levels becomes lower. But I wouldn't say this is true for your overall stress level, because if you are then subjected to other problems that you haven't been training before, then it should not translate to lower stress levels. But if you compare to airline pilots, they train numerous events so that they're prepared for anything that can happen. And you can do that with simulation training, obviously. So you can prepare for the worst nightmares that you will encounter, and then you will have less stress or be well prepared. The problem is that perfusionists, as we have shown, not only run a heart lung machine, so they have you'd have to train in several areas of work to make it all happen, and this is not done yet. So this is very difficult. So to answer your question, I don't think you will find any literature reference on that at the moment in perfusion.
Yeah, I saw two guys that with your increasing op cabs, your perfusionists aren't doing obviously as much on pumps. And George Justison kind of wants to know, do you use simulation for continuous competency evaluation of your staff perfusionists? Because obviously if your off pump percentage is going on, there could be a gap.
Yes, I saw that just saw George's question there. Thank you, George. Actually, you may have a false idea, because the caseload is still quite high. These are the isolated CABG patients, and these were not very high numbers. So majority of cases are no longer CABGs in our hospital. These are pediatric or usually combined cases or valve cases, which are obviously done on pump. So it's the number of CABG is going down, but the others are basically more or less the same. No, we don't do this on a regular basis, although we have done it for the simulation project, and it was then suggested also by the perfusion department that it would be a nice thing to have recurrent simulation training, but they weren't so eager on an evaluation of Indians. I mean, this is something that goes both ways. So we think we are training perfusionists, and we try to create something meaningful for them and give them some techniques. We're not at first hand interested in rating or evaluating the performance, because this could very well lead to, I don't know, stress for the participants, or not wanting to go to the simulator at all, because we don't have to go to the simulator. Unlike as an airline industry, you don't have to sit simulation sessions. So it's a voluntary thing. So if you then rate people and they don't rate very well, so they might not be coming back. So that's it's a caveat there. So I think maybe in the future, if we were to be forced to use simulation sessions to maintain a certification or something like this could change. But at the moment, we don't do that on a regular basis.
Gotcha. One thing I didn't see mentioned either was Samira was asking about balloon coverage in Europe. What's the perfusionist's role? And then I'm going to segue after that answer into, if you're all right with it, talking about cancer coverage just a little bit.
Yeah. I think, Ben, you want to answer that? Or?
Sorry, I didn't get the first part.
Oh, IABP coverage. So may I answer?
Yeah.
Okay.
Yeah.
So of course, IABP is still around, but and actually it's a renaissance, a little bit of IABPs in Europe at the moment. But it's mainly used by cardiologists and not so much in cardiac surgery. And that's why perfusionists, okay, we have IABPs in our operating room and we use it sometimes together, a combination with ECMO as well. But it's not the primary tool to be used on a patient with failing left ventricle. So we would rather use impeller device or any other short-term VAD or ECLS rather than IABP for a surgical patient. And the other ones are the cardiology patients, but these are not treated in our operating room. These are treated on ICU elsewhere.
Concerning the role of cancer, I guess there's a lot of centers here in the U.S. that are doing, me included, that are doing HIPEC, but there's also isolated limb perfusion. And can you comment to how is that going on in Europe? Is there a special circuit you're using? Obviously, the perfusionist scope of practice would encompass this as well, further diversifying all the different things that we're going to have our hands in.
There are
That's right.
so there are similar movements here. There are many perfusionists involved in the cancer therapy, HIPEC, high torque, and also chemosaturation and liver perfusion. Only I am not, because we're the heart center and we don't perform these kind of cases. But I would, concerning the circuit, redirect to some people that are experts in the field. If you want to know more about this, then please get in contact, and I will hopefully provide you with information that is useful.
But I can tell you it's usually the larger university hospitals. And now, as earlier, maybe you know that the heart center was just isolated a cardiac center and not treating any other kind of patients. And now we have been merged together with the large Berlin University Hospital, the Charité, and of course they have cancer patients and they have been doing chemosaturation before. So their smaller perfusion department did this kind of treatments already. And so what is happening is these two hospitals have been merged January this year, the perfusion together. So I expect that this will, the perfusionists will rotate and then learn these techniques as well. So while these patients are not being treated at the cardiac center, they are being treated at the university, at the main university center, and that's what they will use. They also use it already, yes. But in all over Germany, it's usually only some specialized hospitals. It's not very widespread. So these patients tend to get treated at the university hospitals, maybe 10 of them in Germany out of the 80.
You know, I also saw Anthony Aquino was asking, and I saw on your slide, when we're looking at TAVI procedures and the increase, we're seeing similar in the States too, but like Al alluded to as well, we're kind of in most things we're behind Europe, you know, and so Anthony's question was more or less, are you doing TAVRs on younger patients? Because in the States, we're not quite creeping into the young yet. We're starting, but you know, for the most part, it's still older patients. Are you seeing a younger crowd for your TAVI patients?
Okay. Age of
Guys, we're
patients.
just about out of time, so if you can keep your answers short, there's 2 or 3 more questions you want to ask. So just a very brief answer.
Okay, so I just answered. Actually, there's some restrictions on age at the moment. So, but I definitely think that this is going to happen very soon. So at the moment, it's still older patients, and there have been some. You would say somebody younger than 70 would not necessarily get a TAVI procedure in Germany.
Quick question, quick answer, Frank. Seems like you're at the bachelor level. Most of the programs in the States have moved to the master's. Are you anticipating move to a master's for entry-level perfusion?
Well, not for entry level perfusion, but for like for ongoing education, yes. But this has to do with the historical structure of the educational system in Germany. But we're moving to a new facility, to a new university, and we are also going upgrading to a master sometime.
Excellent. Thank you for the picture of all of the graduates. I assume those are being dispersed throughout Germany. Are some of them also going outside of the Deutschland, or are they all in Germany?
I didn't get this. Your voice was muted.
I got the.
Oh, I'm sorry. I apologize. Great picture of all of your graduates. Are they all staying in Germany, or are they going outside into other countries?
No, they're all from within Germany.
One other very quick question in regards to training for the future. Normothermic regional perfusion for donation after circulatory death is really picking up here in the States. Are you also seeing that in Europe?
Yes. But it is limited use at the moment in Germany for legislative reasons. But I expect this going to be happen in the next 5 years. And that's actually good you asked, because there's a training program in the Netherlands now that to train organ like perfusionists. They're not necessarily certified perfusionists, but they call themselves perfusionists because it's not a protected title. Anyway, but we will see that more and more often, I think, in the future, that people are providing the service to transplant hospitals.
Well, listen, I want to thank everybody who's typed in questions and stayed for this wonderful presentation. Ben and Frank, you guys are awesome. Thank you so much. This has been extremely informative. And I definitely, we could go on for another hour or two without a doubt. Right now, we have an open slot in May, but in June, we're going to be very fortunate to have George Justison, one of the world leaders on oxygen delivery, and so much more, as you can see from the title of his presentation. And we invite everybody back during that. And if we do fill the May slot, I'll make sure that that information gets out. Again, I'd like to thank Jeff for co-moderating this session with me, Maggie, who is our behind-the-scenes person from logistics, and of course, Dr. Merkle and Mr. Haupt. You guys were awesome, very, very informative. And I know it's midnight your time. Hopefully not too late to have a glass of wine or a beer before you hit the rack. But I want to thank everybody for participating, and we look forward to future webinars.
Thank you guys, gents. Cheers, gents. Thanks so much.